is the largest sesamoid bone. Sesamoid يعني البone in within the ligament. So there is the quadriceps and patellar ligament, and the patella is in between them. So it's a sesamoid bone, triangular in shape, etc. طيب, how the patella break or fractures? either direct blow or indirect strangles. direct blow انه يكون كسر يعني ضربة مباشرة على الباتيلا فبالتالي breaks, او indirect يعني يكون البيشنت flexing the knee. There is acute strong contraction in the quadriceps, so this leads to indirect trauma to the patella. It can be display transfers, etc. Clinically, if there is a displaced fracture, you will find there is a gap. And we always test what is known as the extensor mechanism. And we'll know the importance of this examination later. So in terms of imaging, you always take two images, anterior, posterior, and lateral views. Example, in this image, in lateral view, there is a displaced fracture of the patella and it's rotated, displaced patella fractures. It comes to skyline view. The skyline view is the best view for the patellofemoral joint, and it can detect any vertical fracture in the patella. There is a condition called bipartite patella, which is condition in the patella where there is failure of fusion of the ossification centers of the patella, and this leads to one area of the patella not fused with the rest of the patella, which is this piece. So this piece here is not fused with the patella. Okay, this line here. So sometimes people who are inexperienced with these type of conditions, they think this is a fracture or break in the patella, but this is not a fracture. This is what is known as bipartite. But in terms of the treatment, if the fracture is non-displaced, then treatment is non-operative. لكن بشرط انه يكون intact extensor mechanism. لكن any displaced fracture, any disrupted extensor mechanism, the treatment is surgical, which is open reduction and extension. طيب كيف نشيك على extensor mechanism? So it tests. We ask the patient to do extension of the knee. Okay, if it is disrupted, this is an indication for surgery. So IRF or patellectomy, either partial or total patellectomy. A very common treatment is what is known as tension band wire, where you put wires and you put K wires in the joint and the bone, and then another wires around this K wire, and this help in treating this fracture. So this will convert destructive forces of the quadriceps, compression forces around the break with the fracture line. So you don't need to know this, but just to show you the idea behind this treatment option. Complications include anterior knee pain, symptomatic hardware, non-union stiffness and defection. The next is knee dislocation. The knee only dislocates if there is tear in 3 out of 4 ligaments of the knee. So there has to be a very severe or a very high energy trauma to the knee to dislocate the knee. So knee dislocation indicates severe injury to the knee. Like imaging is X-rays, so it gives an AP and lateral, MRI sometimes. So initial management starts with the X-rays, do the neurovascular exam. As you said before, that even with normal pulses, there might be injury to the vessels or the arterial injury associated with knee dislocation. As we can see in this image, there is overlap. There's the tibia is overlapping the femur on this anterior posterior view, but on this lateral view, there's a clear dislocation anteriorly of tibia to the femur, so clear knee dislocation. And this dislocation, the tibia goes posteriorly in relation to the tibia and in relation to the femur. So this is a posterior knee dislocation. Always get all the images you need and also do the ABIs, very important in these cases, just to rule out vascular injury. CT angiography is also another important study to do to rule out vascular injuries. Treatment is urgent close reduction, assessment of the neurovascular status. As we said, vascular assessment is a priority in these cases. Immobilize after the urgent close reduction and surgery later on for ligament reconstructions, and also immediately surgery can be done in cases of vascular injury, reducible dislocation, and open fractures or dislocations. Next is the tibia plateau. Tibia plateau is the upper part of the tibia. Okay, so this is the lateral part. This here, this area is the lateral tibia plateau and medial tibia plateau. The medial is larger and it's lower, so more concave shape. And the medial bone is harder. This is why it's less likely to fracture. Most of the fractures, the tibia plateau is in the lateral side. The lateral is higher and convex, more convex, and the lateral cartilage is thicker. So the medial is concave, the lateral is convex. Bony prominences like intercondylar eminence. Okay, so it's attachments for the cruciate ligament, tibial tubercle. It's an insertion for the patellar tendon, and the Gerard's tubercle is insertion for the iliotibial band. So in terms of soft tissue, there is the medial meniscus, the menisci, so the lateral meniscus here is larger. and the medial is C-shaped. The mechanism of injury and how these fractures is valgus force or valgus fluid with or without an axial. Like a patient falling from height, so falling from height with a valgus knee, this leads to break in tibia plateau, lateral tibia plateau. As we can see here, so patient fell with a valgus, so the lateral tibia plateau breaks. The other way the injury affecting the medial plateau. Okay, and whenever there is a combination of forces, this leads to break both uh, both condyles or both medial and lateral tibia plateau. So associated injuries like the MCL, LCL, menisci, also uh, arterial injury, nerve, etc. And always compartment syndrome. As we can see here from this coronal CT scan, this the knee joints, and then there is a fracture. Okay, there is a break here, and there is the breast piece. Okay, so this piece supposed to be here. But now there is a break and depression. Break or fracture and depression. And this, as we will see later, this is type 2 or type 3 fracture according to the Yasser classification. طيب Yasser classification زي ما قلنا إنه type 1 there is a lateral split fracture here. There is a split fracture, so type 1. Type 2 there is a split and depression زي ما شفنا type 2. Type 3 لا type 3 لما يكون فيه only depression ما يكون فيه split ما يكون فيه شيء زي كده تمام. medial إذا كان fracture in the medial side it's type 4. إذا كان bicondylar يكون type 5 أو 6. الفرق بينهم إنه هذا بس bicondylar لكن هذا لا يعني bicondylar زين أو حتى unicondylar مع proximal shaft. So if it's associated with a proximal shaft it immediately becomes type 6. Then, so type 1 split, type 2 split depression, type 3 is depression, 4 is medial, 5 is bicondylar, and 6 is also bicondylar, أو plateau with a proximal shaft fracture. Evaluation زي ما قلنا في أي fracture they all start with ATLS protocol, detailed examination, rule out any open fracture, open wounds, rule out any vascular injury, any neurological damage or injuries. Okay, all these are important in the treatment. طبعا rule out compartment syndrome, rule out open fractures, rule out neurovascular injuries. Then always start with skin integrity to rule out open fractures, soft tissue swellings, compartment syndrome, open fractures, any gross deformity, shortening of the limb, neurovascular status. Always